Maybe we can, yeah. So we start with Dr. Anju.
Good evening, everyone, and very warm welcome. Tonight's topic is actually a very unique and relevant topic. It's role of imaging and medicine and machine learning in intimate partner violence. My name is Anju Agarwal, and I'm a family physician in Sydney with special interest in women and mental health and domestic violence. It is past midnight here in Australia, but it is such interesting and meaningful topic that we are all tuned in, and are especially with our distinguished speaker, Dr. Bharati Khurana from Harvard's Medical School. With this, I'll introduce Dr. Vinita Sharan, who will be mediating the talk tonight. Dr. Vinita Sharan is a senior radiology consultant at Deep Tech Medical Services. Dr. Vinita is also adjunct faculty of Public Health Foundation in India. Vinita is former associate professor San Beda College of Medicine, Philippines. She's advisor of radiology CMEs of GAPIO and very instrumental in organizing the virtual radiology sessions for GAPIO. This is her 6th session under her mentorship. Thank you, Vinita. With this brief introduction, please welcome Dr. Vinita Sharan. Thank you.
Yeah, thank you, Dr. Anju, for the introduction. And greetings of the day, everyone. Wherever you are, whichever part of the world you are in, have a wonderful day. And welcome to the GAPIO Garcio International Lecture Series in Radiology. Our topic today is role of imaging and machine learning in intimate partner violence. And we have actually, there has been an increase in the partner violence during COVID times. And as radiologists, we have been trained to look for signs of child abuse, but looking for signs of abuse in adults is still a way to go. And we have Dr. Bharti with us to elaborate on this. But before I go ahead, I would like to request the audience, if you have any questions, you can put in the chat box below, and we'll have a question and answer session at the end of the talk. And so to introduce our speaker, I would like
Can you hear Vinita?
Yeah, Dr. Sharan, you got muted, I think.
Oh, I'm got muted.
Yeah,
is it
now
okay now?
Okay.
Yes. Okay. So Dr. Akshay Saxena, he is the professor of radiodiagnosis and imaging at PGI Chandigarh. He has special interest in pediatric radiology. He is the president of Indian Society of Pediatric Radiology, and he also heads the same subspecialty for IRIA. And he is also a council member of the IRIA Chandigarh chapter. He's a very awarded person, and it's a long list of all his achievements. But recently, he has received the GAPIO Excellence in Radiology Award in 2022. He has written many book chapters, written a lot of papers, and then he has presented many papers. So I would like to now invite Dr. Akshay Khanna. I'm saying sorry. Akshay Saxena to introduce our speaker for the day, Dr. Bharti, who is also from the same medical college, Maulana Azad Medical College. Dr. Saxena, over to you.
Thank you, Dr. Vinita, for a kind introduction. Yes, both me and Bharti, our speakers for the day, are from Maulana Azad Medical College. And yes, Akshay Khanna and Akshay Kumar are my namesake from Bollywood. So Never mind that. So,
Sorry for that.
no. That's okay. That's okay. But the other two guys will be really proud of this. Um, so, our speaker today is Dr. Bharti Khurana, who is founder and director of Trauma Imaging Research and Innovation Center and an associate professor of radiology at Harvard Medical School and an emergency radiology at Brigham and Women's Hospital. She has completed her fellowship in musculoskeletal radiology at Brigham and Women's Hospital and also holds an MBA from the MIT Sloan School of Management. She specializes in spine trauma, machine learning tools in radiology, geriatric trauma, and intimate partner violence, which she will be discussing with us today. And she has been a very distinguished educator, and she has received 3 times the distinguished honor speak educator award by Radiological Society of North America. So for the people who are not from North America, this is one of the very highly rated awards. So let's hear out what Bharti has got for us today. Bharti, it's over to you.
Thank you, Dr. Saxena, Dr. Sharan, and Dr. Agrawal for very generous introduction. And Dr. Agrawal, hats off to you for joining me in the, at your midnight. But hopefully we'll do this quick, and it will be worth for everyone. So this is my funding information. And so very, generous funding, and I'm very grateful to them. And this is my non-relevant financial disclosure. So just a couple of years ago, United Nations startled the world by sharing this news. The most dangerous place in the world for women is, I want you to think, or we can make this interactive. This was very surprising because the most dangerous place in the world for women is home, sweet home. Because each year, more than 50% of female homicides are committed by their partners or family members. Now, what's more striking is that women make only 20% of total homicides, but more than 80% of intimate partner homicide victims are women. Now, here's probably the most disturbing part in this report. These killings were not usually spontaneous incidents, but part of a long-standing escalating abuse. That means you and I, as society or healthcare providers, witnessed these episodes but couldn't do anything about it. So let me take you to my reading room. I'm an emergency radiologist, and I get one-line history for every study I interpret. So here is a 38-year-old woman strangulated and hit by her husband. So as I was reading this study, another study popped up. This is the comparison study from 2005. Now, this is again fractured arm, but on the other side. And it's from 13 years ago when she was 25. Now, at that time, she reported history of fall, but I know this fracture is more like an oblique fracture, which is often due to violent pulling, not just simple impaction. And also there is some callus formation already. So this is already healing. So in between, she had 68 radiological studies on my PACS. Now, how many times you were imaged due to falls between 25 and 38? The most productive time of your life when you're focused on your family and career. How much time can you afford to come to these appointments? Not to mention the countless visits she had at our healthcare center at Mass General Brigham. I couldn't even count the number because I kept on strolling. So we diagnosed a fracture in 2005, but missed her real diagnosis. Her real diagnosis was intimate partner violence, which is defined as physical, sexual, or emotional violence between current or former partners. Physical assault is still the most commonly reported type of IPV. Now, 1 in 4 women and 1 in 9 men have reported experiencing severe physical violence from their intimate partner in their lifetime, just in the United States. So annual healthcare costs are definitely higher for these victims. We see these patients coming frequently. Even children who are exposed to this intimate partner violence at home have higher ER visits. Of course, it comes with a huge price tag. And more importantly, each year, more than 50% of female homicides have been linked to IPV. Now, the good thing is it's preventable. So we as radiologists, we want to diagnose things early, just like cancer. I want to diagnose things early so that I can save the body It's the same approach we are taking here. We want to diagnose domestic violence early so that we can stop the cycle of escalation and save the relationship. So you talk to most victims, nobody wants to leave the relationship. They just want the violence to end. Now, the biggest obstacle is that patients underreport. We see only the most severe cases of violence and homicide, while the vast majority are submerged, invisible to us, society and healthcare providers. Now we all understand the barriers for victims. In general, victims are scared. They are worried about embarrassment. They are dependent on these spouses. In general, they don't understand our role, and they always like to justify. Now, if you are thinking that it would not happen to you or someone who is financially independent or well-educated, let me share some stories. And I didn't have to go too far. I started hearing all this when I started this project. So this was in 2018. I'm good at hiding my bruises because for 16 years, I've walked down the hallway and no one knew. This was a technologist. I had read her studies multiple times without even questioning. Here is another radiologist. I was in a physical abusive relationship with my physician husband for almost a decade. Here is another male radiologist. I witnessed my mother getting abused by my physician father frequently. And this article came in NEJM, and that became actually a big motivation for me. So here is an emergency medicine pediatrician who is seeing these patients of child abuse, and she's going through domestic violence every day at home. And there were so many things, but I have underlined the most important thing, and I'm just going to summarize it for you. She kept on hiding all incidents and called it fall or skiing accident. And nobody was asking her, even when she was going with injuries, ED physicians were not asking her. And ultimately, she decided to leave that relationship because she sustained a calcaneal fracture from one of the abusive incidents. And then she noticed that she could not run away from strangulation because it was hard for her to run because of calcaneal fracture. So this was the reason, after 6.5 years, she decided to discontinue the relationship. But you can imagine, as ED physician looking at child abuse every day, she still didn't feel comfortable leaving. And here's another surgeon, actually. The reason I got contacted, because she wanted me to review her MRI of the cervical spine. And these are her notes, spine surgery notes, where she came in 2017. She reported as a motor vehicle accident because she was scared of her life and her children. So here is someone well-educated, financially independent. She was not coming forward. She was feeling very uncomfortable. So, and she wanted me to share her notes, by the way. This is from her permission. She wanted me to share her notes with the entire world and let people know that this is very, very hard for victims to speak up, and we need to really help them. So victims present to healthcare providers before they present to criminal justice or social service. Sometimes we might be the only ones where they are getting contacted. So we need to screen that. And, we can talk about what happens in India, but, in many countries, we have these screening questionnaires and we screen them everywhere. However, the numbers are very low. Despite all that screening, we know that 80% of domestic violence patients come through ED, but only 5 to 30% are flagged. And the reason is we have barriers with providers too. So often the providers are uncomfortable with the topic. They are afraid of offending the patient or partner. There is in general lack of awareness and misconception how the patient looks like. So this is a journey of patient and provider. In the beginning, there is lack of awareness. We call it inactive problem recognition in the field of management. Then, in general, the patient likes to minimize because she likes to justify why this is happening, and it's, self-blame is a big part. And then it escalates. And by then, it becomes a social stigma. Children are more important. There are traumatic brain injuries, so they start having cognition issues. They lose their credibility. They are more dependent on their spouses because they might be unemployed by now. And ultimately, when they disclose, everybody's frustrated. Now they are burdened on society, healthcare system, and government. So if you think that IPV is a private thing, it is not a private thing because we are all helping these patients, and we should be helping, but we don't want to come to the very end. And of course, it gives all frustration to physicians because we often look back and question why we didn't call IPV, why didn't she come forward? But we now understand there's a huge stigma for them to come forward. And there's a lot in literature. I'm just going to share one example. This is from orthopedic surgery. The resident responding to the survey, I have never asked one question. Why? Because he has never seen his attendings asking this question. And what am I doing as a radiologist? So this poster came probably when I was in elementary school. We know that we can see stigmata of injuries on radiological studies. And this one, I just did it a few years ago. So this was a CT study, and I made a 3D deformations to show that how this woman was brutally beaten by a hammer. And you can see all these hammer impressions. But that's all we have done over the last 50 years of advanced technology. We can just show these injuries better, but we haven't made any effort in diagnosing these patients. And I'll share my perspective. Everybody's different, but I'm going to share what I think. When I'm sitting in the reading room, I'm just looking at the number of studies. All right, in next hour, these are the studies I have to read. And it's actually not my job to raise the suspicion of IPV. I'm sitting in the dark reading room. My job is to interpret studies. It should really belong to ED physicians and orthopedic surgeons. And now we know why the system is broken, because nobody's taking the responsibility. So this all changed in 2016. This was the time when AI was coming in the, AI just started in radiology because we heard this challenging statement from Hinton that, we need to stop training radiologists. And of course, I'm here talking about AI, I was the only radiologist, very much focused on what AI can do. And I remember there was a nurse practitioner who this wasn't in response to my statement, but it was more in journal, motivating people. Look, we are planning to go to moon, but can we just address this issue of domestic violence? These patients keep coming. We just put band-aids without addressing their root cause. And it just bothered me because we do such a good job in non-accidental trauma in children. In fact, I can lose my license if I don't diagnose child abuse. But when it comes to adults, we just assume that they can advocate for themselves. And we know that that's not the case because I just showed why it's a problem. So anyway, I decided to look into the role of radiologists in identifying IPV, just because I know we could do so much better with, we were already doing so much better with child abuse or non-accidental trauma in children. So I asked my junior faculty members. Nobody actually was interested in doing this kind of study because they thought, it's not going anywhere. So ultimately, I went to my new generation, first year, second year, and third year residents. I made them first 3 authors, and thank God they believed me, and we decided to do the study. Now, the results were not surprising. So we looked at this was a case control study, and we just looked at, less than 2 years of data. First of all, we saw a lot more studies done in IPV cohort. There were more OBGYN findings, more acute fractures. Acute fractures predominantly involved face and skull, and the chronic fractures were also present more commonly in extremities and nose. Now, this is not a rocket science. Actually, people from India, radiologists from India understand this better because we take forensic medicine in med school, and I actually give full credit to my education in India, which helped me to understand this problem and helped me to propose this. So let's understand this better. The target area is often the face. The victim is pushed to a wall. So we'll see injuries of the face and shoulder. And also there are defensive injuries involving the arm. Now, all these things can happen at the same time or at different times, but we would see stigmata on radiological studies. So this led us to believe and propose the power of radiology and AI in detecting intimate partner violence. So by looking at the high imaging utilization, location, and imaging patterns specific to IPV. So this is our strength. We radiologists are good in pattern recognition. Old injuries of different body parts. We have access to all radiological studies. So even though patient is coming for wrist X-ray, we have access to her facial CT, which was done a few months ago. and injuries inconsistent to history. We understand the mechanism resulting in injuries better than anyone else. So we can generate an objective, unbiased report. So we are not worried about offending the patient because we are generating objectively. So this is how people have defined, this is from orthopedic surgery literature, that there are these injuries, they know about it, but this is how I want you to think about now. So there are target and defensive injuries. Okay, so this woman is raising her arm, she's trying to protect her face, she might get injured today, she might get nasal bone fracture or arm fracture, or typically ulnar fracture, but it would happen eventually. Or there may not be fracture, there may be just soft tissue swelling. Sorry. So anyway, I thought I was done. I defined that area, and I just put together a radiographics article. I remember like 2020, I thought I was done. I'm like, okay, here are some target injuries. These are the defensive injuries, and radiologists should pay attention to it. And then this picture got a lot of media attention. So I remember this was Fox correspondent. She was asking me, oh, what kind of injuries do you see in domestic violence? I said, look, ulnar fracture is different from radius fracture. So when you're falling on outstretched hand, you often break radius fracture. In fact, radius fracture is the most commonly fractured bone we see in the emergency radiology. But ulnar fracture is different. If you have an isolated ulnar fracture, that is more a defensive fracture. So we are all radiologists. We have heard that term nightstick fracture. Remember because you are defending yourself by raising your arm because you are defending your face. And that's why you get ulnar fracture. And then she asked me, she's like, oh, so when you see ulnar fracture, isolated ulnar fracture, do you always raise concern of domestic violence? And I said, actually, I don't. But let me check with my orthopedic surgeons. So I remember talking to my orthopedic surgeons after the interview, and she said, and they said, no, they never checked because there is no evidence. So we went back, we started doing the study. So we looked only at isolated ulnar fracture. And our question was, does an isolated ulnar fracture in a woman represent IPV? And can we really differentiate an ulnar fracture due to IPV from accidental causes? And I had like 3 orthopedic surgeons from 3 different institutions. And we noticed that 26% of isolated ulnar fractures in women were attributable to IPV. That means they were disclosing IPV at the time of injury. And then 32% of women were either confirmed or clinically suspected to have IPV. So these patients were not disclosing, but later on decided to disclose, or they never disclosed, but the clinician always suspected IPV. And there was something else we saw. So fractures due to domestic violence were frequently non-displaced. In fact, they are like very hard to see. You really have to magnify. They're often transverse, non-communicated, and they're typically more mid and distal shaft. And the fractures because of accidental causes, these are like definitely accidental causes, witnessed causes. So these are often communicated and displaced. Now, I did not know why this was happening, but we reported this. I just thought maybe it's intimate partner violence, maybe the energy is not severe. But then I learned from my multidisciplinary conferences, from our social workers, and actually coming from patients directly. So these are all examples. And what I learned from them was that these fractures often happen when somebody is holding your hand or wrist very tightly. So arm, and so as they're holding it, it's not like they're using sticks, or, I mean, they might be using something else too, like baseball bat. That was actually, we had few cases like that. But this is more often because of that tightness, that pressure. That's why these are non-displaced, non-communicated, transverse, and very hard to see. So mid to distal ulnar, non-communicated. Then we started looking at the injuries, because I decided that we have to review these patterns on radiological studies to really understand them. Otherwise, we are just looking at the old literature. It's not going to change anything. So we started seeing similar patterns. For example, in hand, we saw actually finger fracture was one of the most common fracture of all upper extremity, not ulnar fracture, but rather finger fracture. And these are, again, more medial fractures. Makes sense, as these are defensive fractures, non-displaced, and often non-comminuted. And they were associated facial findings too in some of these patients. And more importantly, some patients were coming back with the same hand injury. And then we understood from our social workers that often abusive patterns are recurrent. And actually orthopedic surgeons had very similar experience too. But my surgeons were not happy. They were like, no, Bharti, you cannot call all finger fractures because of IPV, because finger fracture is the most common fracture we see in our clinic for women. So we looked at the national database. So they were right. Finger fracture is more common to break your finger because of accidental striking rather than domestic violence. I mean, this is how they are reporting. But more importantly, it is actually not common to have finger fracture because of falls. So again, pay attention to the history. And similarly, shoulder fracture, areas of bone in shoulder, it's more common to fracture them because of fall rather than accidental striking. So coming to the face, so we know that more than 2/3 of women with facial injuries are assaulted by a husband or boyfriend. I mean, this is like a well-known thing. When I talk to my facial plastic surgeons, they're like, yeah, we know that, but we never ask because, again, they are always uncomfortable. It's just a feeling like, what can they change? And more than 90% of domestic violence patients will sustain facial injuries. And we know that the most frequent injury is contusion. So, we are developing this AI tool. So I want you to make sure when you are reporting your facial CT, please put soft tissue swelling. Make sure that you are putting in the report. Actually, I'm putting in the impression, and I would encourage you the same way, because that helps us with the AI tool. So we looked at our study. These were like, all facial fractures. So fractures were actually more common than isolated soft tissue swelling in our study. And it makes sense because we noticed that even ED physicians can be biased. So if somebody comes with domestic violence injuries, often they don't get CT. They get CT only when they are suspecting fracture, which makes sense too, because these are relatively younger patients. We don't want to radiate them. But often it's the nasal bone fracture. So nasal bone was fractured in almost 1/3 of patients, followed by mandibular and orbital fractures. They were like similar incidents. Again, no displacement, more common to have associated upper extremity injuries. And there were some recurrent injuries, but over time, and I'll show you like how domestic violence patterns change. So mid-face, it's the periorbital area, nasal bone fractures, non-displaced. And also we started seeing more left-sided dominance. And the left-sided dominance is because of predominant right dominance in abuse in general. So we are, right-handed dominance. And of course, the blow is often from the right side going to the left side of the patient. So again, it's all forensic. I'm applying everywhere, which we learned in medical school. So here are some examples. So this is medial orbital wall fracture, classic injury. And then we also have contusion. And same thing, and this patient also had finger fracture. And then she came back after a year. Now she has nasal bone fracture, again, soft tissue contusion. And so this is like, these are recurrent patterns we see with domestic violence. So another example, so nasal bone fracture, then she developed another nasal bone fracture and contusion, and she has a foreign body. As she was getting hit, there's a foreign body in the scalp, and she also has acromioclavicular joint injury. So coming back to thoracic injuries, so non-accidental trauma in children, we know that we see posterior rib fractures. So I just assumed very similar. And I remember talking to our surgeons, they were like, we wonder if the patterns are different in adults. And of course, I was actually very surprised to see right lower anterior ribs. So we were seeing more involvement of right lower anterior ribs, non-displaced fractures, and they were often associated facial and upper extremity injuries. Now, something I didn't understand, why right lower anterior ribs? So again, interviewing our orthopedic surgeons and trauma surgeons, and of course, patients, we learned that these patients often get kicked. So there is like a foot stepping on their abdomen. And again, it's the anterior ribs which get fractured rather than posterior ribs in children, which are often because of the shaken, when you're shaking the body. So of course, we should have thought about it, but it's only after doing this, we notice the differences. And these are some examples, again, right lower anterior, and then penetrating injuries. So in chest and abdomen, we tend to see these penetrating injuries. So these are stab injuries and seeing contusions. Okay, so coming to lower extremity, now this was a very big surprise. So when we first started, so 4 of my emergency radiology fellows, very motivated, they were working on this. And everyone started emailing me independently. Bharti, for some reason, we are seeing a lot more foot fractures. What could be the reason? So we did see more forefoot fractures in these patients, and they were like recurrent fractures too. And of course, they were synchronous. So we were seeing the patterns, but we didn't understand why we were seeing forefoot fractures. Again, went back to my multidisciplinary team, learned from our patients that often they get stepped on foot, especially if they are speaking something unacceptable in public. That's the only way they are shut down. So stepping on foot, so foot is actually your target. It's no longer defensive injury because I thought they are getting it from running. Remember the article I shared from NEJM, this woman developed calcaneal fracture because she was trying to run away. But we are seeing forefoot fracture. Forefoot is actually a target for these victims. So of course, I have so many examples. And these are often non-displaced. And again, if you are seeing heel fractures too, so pay attention to that. All right, so I'm going to talk about head injuries too, because I will share my perspective. Okay, so I have to make sure I'm going to share my perspective briefly. So often these patients come for head CTs. Now, most head CTs are negative. In fact, in our study, we had so many head CTs. Actually, I remember the reviewer from JCAT was like, are you sure that you have so many head CTs in these patients? Yes, we had 873 head CTs done in 688 patients, and 94% of these head CTs were negative. And I remember, like, when we sit in ED, I mean, this happened to me, I'll be very honest. I was like, okay, she had all 5 studies negative. It's going to be another negative head CT. She's complaining of recurrent headache. And there's like some soft tissue swelling, we just report. I never paid attention to this. But then I learned that there's a lot going on. So negative head CT is also a big marker. And I learned this from our physicist, actually. So this is Eve Valera. She is a MRI physicist. She's for psychiatry. She works for psychiatry department at MGH. And she shared her research with me that IPV related, so we talk about all these football concussion injuries. It's like such a hot topic in the United States. But we don't talk about these IPV related brain injuries, which are associated with poor cognition and psychological outcomes. And often these patients struggle in remembering the incidents, and no wonder they lose their credibility. And she has shown that it's not just, contusions here and there, but it affects the structural connectivity. And so here is our slide again. So most IPV women do get brain injuries. So if we are saying 42 million in US, so 31 million patients are getting at least one brain injury. And out of that, 21 million, so 51% of these women will get repetitive traumatic brain injuries. So TBI is a big issue in these patients. And no wonder we keep seeing these head CTs and we think like something is wrong with this patient, but we really don't go into the depth. And this is the CT I showed earlier. So these are depressed fractures because of, these are hammer impressions. Obviously, I don't want to go all the way till here. We want to diagnose early because this is too late for us to talk about. And of course, you look at the combination injury patterns if you have nasal bone and metacarpal fracture, and same thing, acute and chronic injuries. So there is a way to diagnose. And quickly, I'll talk about COVID because Dr. Sharon also mentioned, and this is kind of old now, but I remember when this was the first time we were doing injury patterns in domestic violence patients, and then COVID came, and all of a sudden we started seeing changes in our injuries. And we published this, sorry, okay. So I'll just do quickly. We looked at the injury patterns from that time and 3 years ago, and we developed actually severity grading. I was actually surprised that we didn't have dedicated severity grading for these domestic violence patients. And it's partly because social workers have done a lot of work. In general, we consider this more as social medicine rather than actual medicine, which is not the case because we are saving lives there. And we noticed that we were seeing a lot more severe injuries during COVID time. So they were like more stab, more penetrating. These patients were going directly to the OR compared to what we saw over 3 years ago. So whenever you're seeing severe injuries, that means you are seeing only the tip of iceberg. Okay, so if you say like, oh, we don't see domestic violence, we just see like once in a while really bad homicides or injuries, that means you are seeing only the tip of the iceberg. So you are missing those injuries. And I was not alone. Actually, as you know, COVID came first to China and then Europe, and then came to the United States. And people were contacting me because I was like still behind. I was still doing things slowly. And COVID actually pushed me to accelerate my work in domestic violence because we were seeing a lot more virtual visits. They were skipping screening questions because we don't know if the patient is alone or patient is with someone who is listening to the conversation. And it's in general, our physicians are now unable to gather nonverbal cues. So they are not seeing bruises on face or wrist. So radiologist's role is definitely becoming more important. And then I looked at the historical analysis. So the first study when I did ulnar fracture, I had actually 2 radiologists. I blinded them to the IPV status and gave them all historical radiology reports. And I was actually very encouraged by their work because our specificity was almost 94% and sensitivity was 75%, which is still better than what I showed you in the beginning. It's like only 5 to 30% right now with screening questionnaires. So for example, this patient has ulnar fracture. Remember that transverse ulnar fracture? But she also had a fibular fracture a few months ago. And a year ago, she had this foot fracture. So when you start putting things together, you can make that diagnosis. So I got very excited. I did another study with all my 4 emergency radiology fellows. I just gave them all studies, and they were not blinded, by the way. But despite not blinding, they could find domestic violence in only 47% of patients who were reporting physical abuse. So that definitely broke my heart. I'm like, okay, we are not doing a good job. But there was a bright light. They were able to identify earlier, before patient self-reporting, by a median of 69 months in almost 50% of patients. So that encouraged me. But we also understand that we have no time to access and review all historical studies. So I work in the ED, and if I spend more than a minute on wrist X-ray, I'm already feeling guilty. I'm like, no, I cannot spend time in looking at the previous history, whether the patient had facial CT or not, had CT or not, how many times she came for negative head CT. So I just knew I had to do something. So there are silos of specialized, subspecialized radiology. I'm an emergency radiologist. I read head to toe, but not everybody does that. We have neuroradiologists who is not going to look at the wrist X-ray. There is cognitive overload. There's so much I can do. And then in general, I just want to address urgent issues. Right now, there is a distal radius fracture, and this is what I want to diagnose. So we knew that we had to bring my previous passion, which was AI, into this work. So this is the tool we are developing. So this is automated clinical decision support tool for intimate partner violence risk and severity. And I'm grateful to so many societies, and of course NIH. They gave me generous grant to develop this. So the idea is, this logo, actually, the purple indicates domestic violence. That's the color which symbolizes domestic violence. And what we are doing is, so we started with radiology reports. Actually, this was before I even thought of doing AIRS. So just looking at radiology reports, we built the tool, and the AUC was not that bad. It was, more than 0.8. But then when we looked at when we chose the threshold, So at 95% sensitivity, there was 64% specificity. And again, with AI, actually, the best thing is you can pick your threshold and change the sensitivity and specificity accordingly. And if I'm taking the specificity of 95%, we are diagnosing it almost 2 years before patient self-report. But if I'm taking sensitivity of 95%, it's almost 3 years. So encouraging, but we know that radiology is not enough. These are not great numbers. We want to diagnose earlier than that. So I knew I had to bring like non-imaging indicators. So let's look at the non-imaging indicators. We know that these patients come very frequently for their health, for injuries and psychosomatic diseases. Now, remember, it's the frequency, not the severity of injury, which indicates IPV. So this should be very clear. Instead of saying like, oh, but this wasn't fractured, so I'm not going to call it. No, if they're coming back, even for soft tissue swelling, this should raise a red flag. And this was already known. So when we did our study in radiology, we did see that these patients had 4 times more studies than patients who didn't have domestic violence. And so you have to pay attention to imaging utilization. Furthermore, we saw that these patients had a lot more studies done in ED during emergency department visits. Now, I know this concept is not very prevalent in India. There are not that many dedicated emergency department imaging studies done. So the other way is to look at the temporal patterns. So not surprisingly, we saw these injuries happening a lot more Saturday and Sunday, weekend. That's the time you are spending at home together. So it's like late Saturday or early Sunday in the spring and winter, we were seeing. So this is the domestic violence. This is the topographic contour representation. And you can clearly see the patterns are just going with that time. And again, it's easy for us to put these things in our model instead of asking radiologists to look for these Saturday and Sunday things. Same thing with holidays. So I'm going to encourage radiologists in India to do similar things for your holidays and see. So for example, we saw in our study that we had a lot more IPV during New Year's Eve, July 4th, that's our Independence Day, Labor Day, and Christmas time. And look at the Valentine's Day, we just didn't have, this is the baseline. It is very close to the baseline, but then we had more peaks on other days. So I was very proud of my work. And then somebody texted me this: how to hit a woman so no one knows was Googled 163 million times. Now, this was a fake news because the writer didn't do a good job. She just looked at the number of searches. But this text bothered me a lot. And we knew that. So then I was told that if somebody Googles this, actually, my work also comes. So I know, like, as radiologists are learning from my work, abusers are also learning. They know how to avoid things. And we expected this. So we looked at the spine. For example, I learned from a patient that how she gets hit often on abdomen and back just because facial injuries are too obvious now. So IPV does get old and the injury patterns change. So we saw these injuries and we were like, okay, it's going to be very hard. But then I went to national database and I wanted to see how IPV looks like in golden years when IPV gets old. And again, people were right. We were seeing fewer neck and head injuries compared to younger years. There were more trunk fractures, more sprains, and less contusions. Now, the biggest surprise for me was that more than 1/3 of my older adult IPV victims were men. And this is a huge national database. And that was very surprising. So of course, I got motivated to look at men. And this broke my heart. It was actually very hard when I was writing this article because I had to bring 3 psychologists. I couldn't really understand what was going on. So I had 3 psychologists from different continents. I had one from US, one from UK, and actually 2 from UK, different parts of UK. And we were trying to understand why this was happening. So what I learned, that women being weaker in physical strength often use sharp instruments like knife to injure men. And this is the reason we were seeing a lot more lacerations. The injuries were a lot more severe. So remember, men, so we talk about social stigma. There's a huge social stigma for men to come forward. Men are often uncomfortable. They know that they'll get ridiculed by folks in healthcare. So often they don't even come unless the injuries are very, very severe. And no wonder there were more hospitalization in men. I mean, this is a significant difference because it's a huge database, and that was hard. So and also in general, this is what I learned from my psychologist, that when these patients they don't call cops because they are just worried that when the cops come, nobody's going to believe them and they're going to lose custody of their children. So this was a surprising but well-known to psychologists finding. Now, there are special situations. So for example, pregnancy, 1 in 6 women, actually the abuse starts during pregnancy. And we know so our radiology paper did show that we see a lot more IUGR, subchorionic hematoma, pregnancy loss, and other complications during, because of antepartum IPV. Now, something, fortunately, you don't see, but we see, and this is actually a very, chilling statement, that pregnant and postpartum women in US are more likely to be murdered due to IPV than to die from 3 leading obstetric causes like hypertension, hemorrhage, and sepsis. It's just because we have so much gun violence here. Now, so I built this risk prediction model looking only at pregnant women. And you can see that all these are medical findings. These are all clinical findings. Radiology doesn't even exist here because we didn't see significant differences in radiology. And this is the reason and again, it makes sense, isn't it? Because pregnant women don't get imaging that much other than just OBGYN. We try to avoid, rightly so, giving radiation. So anyway, I just realized I'm a radiologist, but I cannot isolate my work from clinical work. I had to bring radiological findings, non-imaging, and clinical into the tool, the AIRS tool. So this is my vision, and this is what I have done. So we have done radiology part. Right now, we are bringing the clinical findings to develop this clinical decision support. And ultimately, we want to give risk probability to every patient at the point of care, so that we can have a non-interruptive BPA, best practice alert, going into radiology report and EMR. Now, so this is the work. So I'm going to show a little bit, because of the time, I cannot go in detail, but this is, so I'm using holistic AI in medicine. So this is my co-investigator, Dimitris. So he is from MIT, and I'm very, very fortunate to have him and his wonderful students, genius students on my team. So we are looking at the why holistic? So we are looking at everything, just like human beings. As physicians, we use all our senses. It's the same thing. This tool is using all its senses. So it's looking at the tabular data, text, time series. So how patterns change over time. And then also the imaging. So I haven't used the raw images yet. I'm using predominantly radiology reports. But again, things are changing so rapidly, we are going to use that too. And this is like, again, it's still in work in progress, but I'm just going to show what we are getting. So we are getting AUC of 0.92 with encouraging results on sensitivity and specificity. And now if we use clinical findings, we are actually making a difference by diagnosing this 5 years early. So we are just going to refine it more. And this is where I'm going to, invite, actually, before I do that, let me just end it this. So this is our journey with AIRS. So we talked about providers and patients before, but if we are diagnosing, let's say we are looking only at the clinical findings, we are making the diagnosis of domestic violence. And there is no domestic violence, patient is denying, but it's helping in primary prevention. we are actually building this companion guide to go with this tool. So we are educating these patients what are healthy and unhealthy relationships. So definitely in younger age, that's a big problem where they think like, oh, this possessiveness is sort of love, but they don't understand that that can become threatening later on. So same thing with once you have that issue, again, as I told you, that often there is justification. By then, it's too late. It gets escalated. We have more severe injuries. So that is acting. So our tool is going to help in secondary prevention. And then tertiary prevention, I learned from my colleagues from Harvard Law School and attorneys seeing these patients, that because of these cognition issues, often they are unable to talk about their injuries in detail and often change their statements. So the tool is going to help significantly in legal cases as well. So we are helping these patients in all ways. And of course, for providers like us, it empowers us. It improves patient outcomes, and we don't feel frustrated. We feel satisfied. So it's touching many folks, so patients, of course, society, and then clinicians help, and of course, hospitals. We are so busy right now. We don't want to see preventable injuries. And of course, payers. So you can imagine insurance companies are very happy where they can avoid these injuries, paying for these injuries, which are preventable. So I'm thankful to everyone in my center. I mean, we have like so many people from different disciplines, and these are all our articles. If you want to go in detail, they are all on my website. And again, many thanks to our students and faculty members who have done a lot of work over the last few years. And this is my center, and I thank you for your attention. And I'm open to all questions.
Dr. Saxena, you have to, I think, unmute.
All right, Dr. Saxena.
Yeah. Hi. Give me a moment. I'm just struggling with my laptop actually. Just give me a
Okay,
moment,
all right.
please. Okay.
So if there are questions, yeah, go ahead.
Yep. Thanks, Bharti. It was very absorbing presentation, and I'm sure many of us will sleep very uneasy tonight. It's an eye-opener, and before I come up with my own questions and comments, I invite the today's attendees to post their questions in the chat box, which we can discuss with you.
Yeah. Thank you once again, Dr. Bharti. It was a really, really an eye-opener.
It is.
And I think it's really incredible the way you have done so much of work in such a short span of time. And so much information is available. So I think we have one question that says, how did you handle the false positives? How are you determining what is a good sensitivity of ROC?
Yes. So that's a good question. So what is false positive? So first of all, what were my gold standards? So think about this. We know that 80% of domestic violence patients are not disclosing. So right now, when I built my tool, I just pulled all patients who reported domestic violence as my, those would be positive cases. And then all patients who are not disclosing are control patients. But we know that there are going to be so many patients experiencing domestic violence, but not reporting in my control group. So that was definitely a challenge. So when we built the tool, we made sure, so we had actually residents and students going through these reports to make sure, looking at the clinical notes, to make sure that we didn't have too many domestic violence. I mean, there's so much we can do when you have 8,000 controls, but we used many thanks to our MIT folks with LLM, we were able, with both NLP and LLM, we were able to find those clinical notes where they talked about domestic violence. So these patients didn't disclose, but wherever they were suspecting, we got rid of them from controls. Now, the thing is, even if we have false positives, remember that's the whole idea of primary prevention. It's not that we are withdrawing these patients, we are forcing these patients to leave relationship. So in adults, it's very different. Adults, they get to decide. So unlike non-accidental trauma in children, and that's why non-accidental trauma in children become very important, because you have to make sure that you are 100% sure before you make this decision. So here we are sharing resources. And what I understand from my social workers is just like untwisting a pickle jar. So very often, the first person is trying to untwist, may not be able to open. And then imagine sitting at a picnic table, and then it just gets passed on. And finally, a little child, maybe on 7th turn, will open and he'll take all credit. But it's not the case, because we had like everyone contributed. So it's the same thing with domestic violence. Every time you share resources, patients are going to say no. We know that, but don't get discouraged. Again, as radiologists, so I definitely got discouraged in the beginning, because as radiologists, I just wanted to diagnose things. And, just like when we check OR notes, we're like, okay, perfect. I called leiomyosarcoma. This was leiomyosarcoma. That's the thing we always look for, because if it's not, then I feel like horrible, that I didn't do a good job. But this would not work in domestic violence patients, because they are very hesitant. It takes many times for them to take an action. In fact, on average, it's like 7 turns. So exactly untwisting 7 times. So 7th turn, the patient will finally take an action. This is like well known. So it's very hard to say what is false positive, but the AUC I'm showing is based on only self-reporting, nothing else. Good question.
I think Dr. Saxena has a question, right?
Well, it's not exactly questions, some of the kind of comments, like, what would be the, listening to the talk, the first question which comes to your mind is whether this is happening in India as well. Are we is there an elephant in the room? Are we looking at the tip of the iceberg, or we are even missing the tip of the iceberg? So in that line of thinking, what would be the potential challenges in the Indian scenario? Well, one, patients will visit multiple facilities. That is one reason, one thing. Today they can go to one facility, tomorrow they go to another facility, maybe another state, which means it is very difficult to keep track of how many visits a particular patient has made. So that would, the reason I'm bringing it in is, as Bharti said, that many of them had more than 6 visits, 7 visits. So that component of the information would go missing when we are trying to create a model for identifying IPV. Secondly, PACS is not available in most of the places. So even if the patient is kind of visiting one particular place for multiple reasons, well, the PACS may not show up all the old studies. So I would say that only a minuscule of the patients will have their old studies propping up. Third, emergency X-rays are interpreted by non-radiologists many a time. There can be multiple reasons for that. I'm not going into it. Lack of specialized services, or just somebody being in a terrible hurry to treat a fracture. So what I would say is that if a red flag has to be raised in this context, in the Indian scenario, we'll have to train the non-radiologist also for this particular condition. You'll have to sensitize the non-radiologist, especially the orthopedicians, the general physicians, anybody who is dealing with the patient in the emergency area. The past history, well, it is no rocket science that many times it will be concealed or overlooked. So the one thing which I'm would be looking forward to is, which I would like to ask as a question to Dr. Bharti, is what would be the red flags at a single visit which will be helpful? That the patient comes, you have a single pointer and you red flag it. Okay, there's a non-displaced ulnar fracture, fine. I can understand, and that can be red flagged as a high risk for IPV. So are there more red flags which can be raised at a single visit, and whether it is the responsibility of the radiologist alone for those red flags, or more treating physicians would be involved with that one? Bharti?
Excellent remarks and great questions, Akshay, as always. So, okay, I'll try to remember whatever questions you said. So please interrupt me if I miss anything. So going back, so from the last concern, what are the immediate? So first of all, the air stool we are building, we are actually looking at on the first visit, the current visit versus prior visits. So air stool is definitely going to help there. And even in the current, you do get history. So it's not like you are reading in isolation. And right from the beginning, I said, this is not radiologists diagnosing things sitting in the dark reading room. It is a multidisciplinary effort. So very often, so I don't put it in the radiology report. Actually, we went through that phase too. So we are no longer, actually in the beginning, I was putting in the radiology reports, and I learned from my social workers that often they have controlling spouses and they are going into their EMR, patient-centric tools, and they are looking at their reports. And if I'm raising suspicion of domestic violence, they're already making some kind of judgment and probably further inhibiting this patient to talk to healthcare providers. So I learned that lesson, unfortunately, hard way, and I stopped putting that. And I teach everywhere, don't do that. Second, so it's best to talk to the ED physician. And this happens on almost every other day. So you talk to the ED physician and, ulnar fracture. So I get a lot of emails from all over the world about ulnar fracture. I'm worried about this. And then he would say, yeah, the history didn't make sense. She was talking about fall, but she doesn't have, any other injury, or you would start noticing. And then also, like, when they're taking prior history, yes, this patient, substance use is a big issue, psychiatric disorders, mental health, intake, and again, some, of course, there are like stigma associated with each element I'm talking about, but you will get that history. Injury patterns wise, of course, we saw more upper extremity injury. These are defensive fractures, more on the medial side, non-comminuted, non-displaced, mid-facial fractures. Injuries inconsistent to the mechanism. I mean, this is the reason I keep going back to a national database, because patients are not disclosing. There's so much I could do with Mass General Brigham data. I had to go back, and this is my opportunity to invite you to help me with this research. So Akshay, as you mentioned about issues in India, perhaps if you are willing, or if people who are listening or watching this recording, if they are willing, I am actually very open to bringing them to our platform where they can look at the current studies only and see if we can see those patterns. So patients are not disclosing, and I know this is a huge problem in India too. So if we can do that, I think that would really help, because I have like 1,500 IPV patients so far I have worked on and published only out of that, like for 688 patients. So I definitely need that help. I want to bring more geographies. So India, so I have like talked to different countries wherever I go, and I would love to bring interested folks from India to help me.
Let's see if it works out. But
I think Dr. Anju also has a question.
yeah.
It's more a comment, Dr. Khurana. What an excellent talk, and being the family physicians here, because I suppose we think we are the first exposure to a patient with any domestic violence. Before they reach all those injuries, as we talked, that's where we are. We try to pick it before it goes to the stage. And as you excellently said, it is just too hard to pick it in the beginning sometimes, because there are so many reasons they don't want to talk. Their partners come with them and they're hovering and they can't talk. So there are clues which which you need to pick that. But it's an eye opener. The whole talk was eye opener, that how much they can injured, and especially that skull which you showed with the hammer injuries. It is just so sad, and appreciate the work you're doing. So it's just a compliment rather than a question. Thank you.
No, thank you so much, Dr. Agrawal. I'm so grateful to you for coming, and these were like great comments. Thank you.
But one quick question: is there any possibility of you as a radiologist or any of your team member running into a medical legal dispute that somebody says that you brought about kind of a diagnosis which has destroyed our marriage or something like that?
Oh, so no, so usually we get involved with so I am actually trying to avoid getting involved in medical legal cases, although a lot of my surgeons are involved, because we often have, so remember I talked about tertiary prevention. So right now our tool is not ready for, the tool is not going to the court, but we have all evidence. So our surgeons, so I usually forward these cases to our surgeons, who often go to the court and explain why injuries can be defensive or target. But patients, remember, this is like patients who are advocating for themselves. I mean, if they are making their decisions, we are fully respectful to that. We are just trying to help them. Where patients need help, and again, I can share a story. I think this is where this was during her childbirth. There were concerns, and they talked about, and this is before I started my work. But I hear these encouraging stories, and the patient refused. She said everything is great, and the spouse got also upset. And then this was baby who was born. 4 years later, she was actually at barber shop getting her son's haircut. And that was the only moment she decided she was alone. And she had that card she got during her childbirth from Brigham and Women's Hospital. She ran, used that card, called her hospital, and came for help. So again, saying that, and they were very upset at the time when the concern for injury was raised, or when the concern for domestic violence was raised. But again, as I told you, you don't know what's happening in their lives at that time. But then over the years, sometimes it's like inactive problem recognition. We talk about a lot in business school that you don't even know what's happening. People are saying, and you are like ignoring it. So again, blaming patients or blaming somebody, that's not the issue here. We are addressing system deficiencies.
Bharti, just to extend that problem a bit more, like, I mean, I'm not sure whether I'm kind of looking at the future of your tool, but I mean, we kind of, the interpretation we'll make out of the tool is, okay, there's a 90% chance that this particular patient is having IPV. What next? I mean, can it be counterproductive that it is talked to the patient and the spouse by somebody, A, B, C, D, psychiatrist, any social worker, anybody, and it kind of backfires on the patient? Is that a risk?
No, so that's why we have a tool. So we expected all these complications. I mean, fortunately, I have a wonderful multidisciplinary team guiding me. So the tool is not just coming. We are not leaving radiologists alone. It is coming with a complete package. So we just built this companion guide. It tells you everything, who is getting involved, how you're approaching patient. And we don't talk like, so I don't know if you're familiar with trauma-informed care. So that's the approach. Okay, so that's something we have to make sure. So that's exactly. So nobody's blaming, nobody's saying trauma-informed care approach is a separate thing. So Google it, and I'm happy to share the document. So our folks talk about it. So this is what we use in this country and many other countries too, that the idea is not to blame anyone, but to let patients know we are there to support them. So that is called trauma-informed care. Nobody's telling them to leave the relationship. That doesn't happen. It's gradual understanding of what they are going through and how we can support them. And to be honest, so this is what I've learned from patients. Patients want us to recognize that they are not alone in this. When they start understanding like, oh, this happened to the other person too. Oh, this is a known thing. We thought it was just unique situation to us. That gives so much empowerment. And we are talking about empowerment in this era, and fortunately with social media, we can do these things. So anyway, trauma-informed care, that's the right approach. It's not like blaming someone or, yeah, I'll share that article.
Sure. I think I'll hand it over to Dr. Vinita Sharan. We probably are running behind schedule.
Yeah, we are. I mean, it's a very interesting topic, and it's really nice to hear so much information on this. And I think we have different challenges in India. I mean, you know, there's a comment that in India, there is a challenge between doctor and patient ratio. So doctors hardly get time to just hear the symptoms of the patient. They don't have much time to understand what went behind the, you know, incident that the patient went through. So with this, I think I will end the session, and I would like to thank you, Dr. Bharti, many more times, because this is really an evolving area of work. And I think while I was listening to you, I mean, there are so many aspects of domestic violence. It can also be geriatric violence and, you know, many others in which this can be applied. So thank you so much. And Dr. Akshay Saxena, thank you so much for chairing the session. And Dr. Anju Agarwal, thank you so much for staying up past midnight to give us the opening remark, and that's really credible. And I would also like to thank the participants for their presence, and it has been really nice to hear from Dr. Bharti for everyone. And thank you, my GapYo team, especially Mr. Jitendra Malik, who is the backbone of all our GapYo webinars. So without him, we can't function with this webinars. So thank you, everyone, and have a very restful rest of the day wherever you are. So thank you.
Thank you.
Thank you, everyone. Good night.